Nous allons reprendre nos débats. Voulez-vous vous asseoir, s'il vous plaît, merci.
The debate is about to resume, so please come in and sit down. We're going to talk about what we could do with CNAM's data. CNAM being the French Health Insurance Fund, of course. We have Didier Bazocchi, Jean-François Bergman, Nathalie Bellet, Marc-Antoine Lucchini, Dominique Polton, and the debate will be led by Claude Le Pen. I think there are some papers that have disappeared off the table. Are these papers you don't want us to see? Stolen data? What about mine? The table has been cleaned up. There was a lot of paper on it, and the papers just disappeared. Nothing left. Right, so we've got 45 minutes, and that's not very much to talk about a subject which is along the same lines as what we heard earlier, but it's a little more down to earth, because we're talking about a gold mine, which we don't use in France. You heard last year about releasing health data. Releasing our data, and the Health Insurance Fund were accused of having built up this huge system for its own use, whereas it ought to be given to the patients. There was a petition, an article published in Le Monde, and we're going to take a closer look. And then we've got the health law, Article 47, which was mentioned several times, and two subtitles on the national health data systems. Another concerning the National Institute for Health Data. So we're going to take stock of this issue and take a look at what the insurers are doing and what belongs to private person, what belongs to others. Are we in open or closed data, or other problems related to this very down-to-earth subject. We'll start off with Dominique to see what it's all about, and we'll take a look at the legal angle. Then with the health professionals and the insurers, we'll see what they're going to do with the data and see how things are going to likely to be able to go awry with this data. So you were in charge of CNAM for many years. Yes, I managed CNAM. What is CNAM exactly? Well, CNAM is a huge pile of health forms. It's dematerialized. And what you've got to take a look at is that there are a lot of things that may be criticized at this table today. We are often told that we should never have built the system, but I think we did a good thing there, because at the beginning we started building up a system including all the population with all the data centralized, all the systems lumped together, and it puts France into a wonderful situation in comparison to other countries. We heard that it cost 2 billion euros. No, I don't think so. I think the cost price was not as much as $1 billion. But it's a great heritage. It's a fabulous heritage, in fact. These are health forms. On those forms, you have exhaustive data concerning all the population, the capacity to track everybody's health trajectory, which doctor they saw at which hospital, which procedure, which diagnosis. And in a certain way, today, we don't have any clinical data, nothing on risk factors or diagnosis during the consultations, but we do have a certain amount of medical information. And through algorithms and statistic manipulations, we can actually make it tell us quite a lot of things, and we do so. We use it. We probably don't use it enough, but we do use it. This is something that you manage with the hospitals. Yes, we do. And people who die, we know the cause. Yes. And when we're told that we've been sitting on the data since forever. We haven't. The law of 1989 or 1988 created it, and when we started the system up, we chained it up with the hospital data in 2010, and the mortality data came along later. So what do you do with it at CNAM? Because all the different health insurance systems lump together the data, and what do you do with it? And who's it open to today? Before the law, who was it open to? And do you do something different today? Well, we have the data, and we do give it to other people as well. We do a lot of things ourselves. It's a tool that enables us to sort of examine the health system and see how it's doing, talk about prescriptions to the doctors, and it's an essential tool for risk management. We use it all the time as a supporting tool. We have a tradition of regulation in France, which is designed to try and promote the right health care, and it enables us to know what goes on in the system. And today we know this better and better all the time. We're able to compare the professionals and make comparisons, see whether the patients comply with the recommendations. This is what we do for the CLAM, at CLAM. And once we could do this, since the data could be used for safety purposes, we now have a partnership with ASM, and we've set up a team that's dedicated to safety tests on drugs, but also on health products in general and treatments. And we work in partnership with the ANSM. The head of ANSM is here in the room, so he won't contradict me. But you don't always hear about this in the news, but we do actually work on the safety of a certain number of health products. Up until now, this has been done on a case-by-case basis. There's not been any use of the data to make money. And even the Transparency Commission recommended the use of the data for the monitoring of these products once they've been put on the market. And in Article 47, it does give indications for the use of drugs. And what is the law going to change? And how is it going to manage the alternative between opening up and protecting the data? Because it's sensitive data, and this is probably the reason why the access has been restricted. Yes, the principle in the Article 47 is opening up the system. Well, that's progress, but the regulations are very complex, and they add on the fact that you've got to justify the public interest in doing so. There are legal safeguards because there's no criteria to assess the use of this data. And for years, many of the users have been using this information, and they've already justified the fact that they use them for the right reasons. And you've got to remember that the French system is the one that protects health data the most in the world, and everybody agrees that sensitive data must be protected. It's the very core of your public life. So it's sensitive data that are a player that have other challenges to face, and they're capable of processing this health data in the right way, in legal conditions, and they've proven their capacity to do that. Are there a lot of complaints? Well, that's another reality. Take a look at the figures. The annual report of CNIL last year didn't even identify the health system. There are 18 sanctions that are applied every day, and there wasn't even one on health data. I'm not saying there is no risk or nothing at stake, but the system has proven that it's effective. And in the drug industry, we've never had any complaints for illegal practice. The sector is perhaps underrepresented, but the players are mobilized and they don't want to be overregulated because they have patients to care for. They've got to assess the drugs as best they can. And they're players that really have to be considered in this respect. So it's all very complex. For the industrialist or the insurer, things are extremely complicated. Of course, there are procedures to be followed, and they agree to do that. But there's an organization that's going to replace the Institute for Health Data. Above all, they've got to set their end goals and prove that they do aim at those end goals. In the Code of Public Health, you've got things that are stipulated, and there's never been anybody has actually been fined for this sort of problem. But you've got to do a study or go through a trial to perhaps in the long term. There's data that is going to open up. The first thing is that anything that is not nominatively identified will be opened up. It won't be traceable. The use will be fairly limited, but in relation to the previous situation, I think that one of the first merits is that it clarifies the dogma behind the system. In 2002, there was a decision that said that people will have access to different levels of data, and then after that, we had another decision on using these data for monetary reasons. The first thing is that everything that cannot be identified will be open data. And it's actually rather hypocritical and not very coherent. Secondly, you've got information that can potentially be identified, and there will be two types of access for this. Some organizations will have access by decree, but once again, according to their interests in the data. There are some data that are useful for an assignment, including for the public in general. There'll be rules and procedures which we're going to have to think about and draw up. And then on the third level, you've got identifiable data, but that will only be used within the scope of public health. You've got anonymous individual data on the second level, which could be re-identified if you cross it with other data. And that's something that will be assessed by the certifying organization. Jean-François, what can a clinician draw from this data in daily practice to start with, and also in your role as an assessor at the CNAM for transparency at HAS? From the medical standpoint, is there any advantage in having this data? Well, on all levels. Let's start with something nice. It's true that an effort has been made to open up the data and make it easier to use for the purposes of teaching and training, and that's quite remarkable. Once you've done this, obviously, either you convert this into gross megadata. It's the minimum that you can do. It's something fairly simple. Or you go for clinical research in epidemiology, and you've got a wonderful tool there on condition that you keep to the real principles of clinical research. That's to say, a protocol, an objective, a scientific committee, evaluation criteria, and not just in real life. I want to know how this is going to end up, because otherwise you're going to go into perverse little games between the regulators and the industrialists. One's going to ask for this data and then say that they don't really need it. And then you've got prescription and the use of the drugs by doctors for the patients. And you can't do any precise study on use and misuse without having a system to code the diagnosis. You've got to code the diagnosis. Kaiser and liberal medicine does that. Everybody does it. And for reasons that are extremely old-fashioned, and we don't code diagnosis. So how can you know what's going on if you've got a prescription, if you don't know what the diagnosis was to start with? So we've set up a commission to get rid of the principle of the precautionary principle. But this year, I think what we ought to do is try and make sure that they do set up codes for the diagnosis. I'm sure it's not going to work, but we were talking yesterday about DPCs and FMCs. Everybody knows that you go to FMC on subjects that you're good at, because you'll be able to show off a bit. But if you analyze the diagnoses and the treatments, you can say Dr. So-and-so is not really good in gynecology, but he's good in hypertension. On the coding of diagnosis, there are 3 codes in the hospitals, and so it can be done. And we'll see how Dominique thinks about that later. But to know more about the subject, the products are very specific, and the advice for use is specific as well, after failure and with the third use and so on and things like that. With esophageal varices, for example, or head, Mr. Martin takes propranolol. His wife takes it for migraine, and his son takes it for something else. Okay, so let's move forward and go on to the 2 nasty guys in the round table, the industrialists and the insurers. We need the nasty guys too. Since yesterday, we've been saying that they're nasty, but we do need them. We'll start with the insurers, who are the people who set the premiums. And if you're connected up, you could perhaps give us better rates. And if we're connected up, that'll be possible in real time. So how's the insurer and the complementary schemes going? How are they going to steer the system? They're profit-making associations, so it's got to be something that makes money. Well, in France, 80% of the complementary insurance funds are non-profit organizations, and they want to remain non-profit associations. So culturally, they're probably not going to want to do that. Secondly, today, we already have access to a lot of health information. When we go and ask for a loan to buy a house, obviously, they ask you for a lot of data and so on. And this data is data we already have. For as much, what we see is that on the health insurance market nowadays, nobody is going to set the rates according to how much healthcare you consume. So it's a false problem today, but it may not be in the future. To refer what Laurent Alexandre was saying earlier, in the future, Google may do that, and probably will, because they've got more information than the insurers have. They know exactly how many steps our insurers take every day, and in the future they may use that information on their behavior to get the insurers to compete, and that's going to break the mutual societies, because if a bad risk has to pay a big premium, there'll be no more mutuality and insurance, and we're going to create critical situations for individuals who can't be insured. So the risk is there. It's not in the myth that the insurers are going to set the rates according to the data they get. The challenge is not that at all. It's not purely an economic one. If you supply them with something to raise their premiums, it makes no sense. If they have a chronic pathology or a surgical operation, so that they can go and have the operation or improve their compliance, then it can make sense for the people concerned. It also makes economic sense for the balance of the complementary health funds. The central challenge for the access to this data, which of course has to be safe, is to improve compliance and pre-medication before an operation, for example, post-operative monitoring, and so on.
So we don't see why we don't give them this information. Now, you're saying that the €5 and the pedometer has no meaning. But this is the example that we give. Why is it not meaningful? Is it the problem of the insurance company? It's not your concern? What are you saying exactly? It's very simple. It's very simple. We've got 3 million insurees. 1 out of 100 coming out of hospital has an invoice of €5,300, if not more. So it's the additional insurance company that pays that bill, and the role of that is to pool the risk. Now, if we manage this surgical episode, we can save 5, 10, 15%, and with the monitoring and re-education, we can make savings. So we can make central savings. So we absolutely need to optimize this care episode. Providing an insuree with a pedometer whose effects will be seen in 10, 15, 20 years' time, that has no meaning because the insuree will change their insurance company in the meantime. Okay, let's move on to our industrialist, our other bad person, who is with the Director General. So insurance companies via the Federation of Insurance Companies, they provide an access, even if it's a referred access or a theoretical access. Now, they don't have access even via these different bodies. So again, it's something that's open, but why? So I'll start with a very positive statement with the intention of Unitext. And potentially this is a historic moment, not only in relation to the potential and wealth of the data, but also in relation to the fact that they have potential. They can break down silos. They can improve collaboration between industrialists and administrative bodies. So I'm very positive from that point of view. But at the same time, there is the question of how do you put that into practice from a legal point of view. And what we're actually worried about in relation to what's already been said is to make sure that we meet the requirements of speed that are going to be ours in relation to the possibility of using these data. So the major challenges are at 3 levels. First of all, in terms of research and innovation. So upstream, for example, with the potential of these data, we need to talk about the improvement of monitoring of patients, the fact of being able to follow them while they're taking their treatment. And the third point concerns, economic efficiency. This is a key subject as well. These are the 3 major challenges, and I would just like to describe them. Now, we need to come back to something else. We are, as industrialists, aware of the sensitivity of these data, especially, when it comes to identification risks. So, we're talking about partnerships and exchange, but we are already aware of the risks. We're aware of the importance of regulation and the importance of this data sensitivity. But we have been limited in our ability to use them. And I can give you some examples of studies or projects that we could have, where we could have used this access. So the three major challenges, I've described them: research and innovation. We need to encourage public and private research, thanks to the possibility of doing large-scale epidemiological studies in order to understand the needs of patients and to pair research and development programs up with database studies, so create a dynamic movement in relation to the ecosystem that is really going to encourage research in France. And a very ultra-competitive international context, research is draining away from France. This is important for groups. You can think about the UK database, which is very much used. And I think this is going to create another base which has much better content. So there are other limits, of course. I think that whatever the case, it will create a positive dynamics. And we're talking about a key subject here, research and innovation in France. That's the first point. Now, the second point is monitoring patients, understanding how the treatment is used. So that's post-hospitalization. Yes, for example, being able to check that they are using our products properly, understand, if you add efficiency data to what's already been demonstrated in clinical studies. Now, there are certain limits in real life, of course, but, we can provide additional support to some of the programs that are carried out and perhaps detect adverse effects that have not yet been identified through clinical studies. Now, all of this is going to encourage the possibility of following the way their treatments are used. For example, if you look at risk management and the obligations that we have when we put out our innovative products on the market, there are contradictions. Laboratories have to be responsible in the way their products are treated, but they're not allowed to access the databases that would allow them to be responsible. So we need additional monitoring, but that is going to be expensive. And there's another aspect that's important when it comes to access. We've got to have controlled costs so that we can develop and multiply this kind of analysis. That's the second point. I'll just come back to the third point now. We'll come back to that. We've got to be efficient. We've got to be able to measure management costs. We've got to look at a path-based logic. How much does it cost? But what about events? What about expenses that can be prevented if there's a medical and economic study? We need to strengthen these studies. Let me just give you an example that is very dear to me. We have partners in the room here, and yesterday the Minister of Economy mentioned this. We've got a study underway, for example, which is the broadest study on diabetic patients, while measuring how the telemedicine platform might prevent some of the problems. And we've asked the CNAM to have access to the same cohort so that we can measure the relative costs of the cohort, and we've never received an answer. So if we can break down these silos, and we're talking about a study, research that will be very positive. It will be the biggest study ever carried out on a telemedicine subject. So you can see where the potential is. It's huge, this potential. And then, of course, there is the idea of setting up, the operational setting up the system, which entails problems. Now, Jean-François, we've been talking about diagnoses. Is it possible? Is it feasible? Are you thinking about it? Can we have the encoding? We've been talking about the encoding for many, many years. And another question, will the CNAM have the resources? Because you are operator of the data by law. Do you have the resources? We've already mentioned this. You've said yes. Will the CNAM have the resources to be able to meet this increasing demand? Now, perhaps the first thing that we can say is that we can always say that at the end of the day, it's not great and we need more. I think that what we have is already great, and if we can get organized to use it properly, that would be great. I can tell you, and I know that the CNAM doesn't tell us everything. There are many, many clinical data that are missing, but I can tell you that we can do many, many things with the resources that we have, and we're realizing the number of things that we can do with algorithms. Now, perhaps we don't have the right kind of accuracy in terms of compared with clinical data, but the first study that we carried out at the request of the NSM after Flurex was a study of an antibiotic treatment for which several studies had been carried out across the world. At Kaiser, they had the same results as us, and we were the first to see anything significant in terms of outcome. This was possible, I think, because we processed the data properly. But I agree with you. So after adjustment, I believe. Yes, but what I'm saying is that we've got results, they're published in the right reviews, and the others found the same outcomes, and we all agree to the results. We can do many, many things. And what I'm sad about is, because we say all the time that we need more resources before we do something. Now, I'm not talking about encoding and diagnosis, but I think it's going to become increasingly easier because we've got medical software. We'll be able to harmonize a certain number of things. We'll have modules that will allow us to extrapolate. So it's not just a question of encoding diagnosis in a traditional manner that is outdated. So it's an option, but I think we can do it elsewhere. And this is something that we haven't said through the law, but it's something that's very positive. This is something that we already do, in fact. There are people who come along with registers and cohorts, and we fit people out. We look at the constant values. We also look at registers according to disorder, and we kit people out with the right equipment. This is something that's possible today, but it's very complicated. It's complicated for researchers, especially when they want to use the SNIA. Now, the SNIA is the health identifier. The national system for data identification, this means that we have a receptor where we can, fit out a certain number of things, and it allows us to say that we can have a sample of medicine, of doctors who would be encoding the data. So, we could have a diagnosis that covers a certain population. Now, very quickly, tell us about the data trajectory. It goes from the surgery, it goes to the CPAM, it goes up to regional level after a first compensation, then it goes up to a national level after a second compensation, and then it's provided to users. Yes, it's encrypted twice, once when it leaves, once when it arrives, so that we can't go backwards, and in a large national warehouse. Now, for several years now, let me just say, people don't come and see us directly for data. It's always by the IDS, the National Institute of Data. We do what they ask us to do. It's not us that we're not the ones who decide. Jean-François, are you convinced? This is anti-natural. Come and see me. I'll give you a prescription. I'll give you medications. You say to me, what's the matter with me? And I say, well, it doesn't matter. That's not how, things happen. The diagnosis goes hand in hand with the treatment. And if we do the overall analysis of the situation of this CNAM data system, it's a bit like, you've got Harpagon on his box. He says, I've got nothing. Everybody thinks he's very rich, and in fact, we don't really know what he's got in his box. And in fact, you've got the three Tartuffes. It's the CNIL, the Data Protection Act Committee. You've got the Council of Doctors and the medical unions. Don't tell them. So it's really a question of absolute hypocrisy. Now, I don't know whether it's academics or whether it's the payers, the agencies, and the industrialists who are told, we've got to provide data to the CNAM, so that either their treatment is very mediocre, or the medication is good, but they still have their wrist slapped. So probably the core of the debate this year is the imaginary doctor and the patient in spite of himself. So we've got a patient with data directly or indirectly linked who is perhaps ill or not, but there's something that we've never brought up, and that is the false positives. Billions of data. What if all that data were false? What do you do with that false data? Is it because the encoding is not good, or what? What do you do with it all? So if, for example, you diagnose somebody with pulmonary infections because they haven't walked their 6,000 steps, what do you do about that? And the imaginary doctor who leaves, he diagnoses his patient without seeing the patient, that doesn't exist. So are we not overusing the data? What about the clinical involvement of the doctor? Are we not talking about collective data, epidemiological data, data for assessment based on a group rather than an individual? Are you not talking about something that is not the subject of the data at the end of the day? I'm sorry. If they're as rubbish as that, why does everybody want the data? I didn't say the data were rubbish. I said that they were 1,000 times more useful with the diagnosis. If my garage gives me a bill for 240 euros and I say, what did you do? And he says, no, I'm not telling you. You're not. People want to know. Okay, so Didier, we've got 5 minutes left. Yes, what the CNAM is doing is brilliant. The data are rich. They can be improved. The CNAM is making progress. There's a positive aspect in the law, which, of course, is the legal securing of all of these aspects. All of that is positive. I don't agree with Jean-François in relation to the CNIL. The CNIL has made progress. It's more pragmatic. When there are the files are very well filled in, so there is no problem. I have no problem with the CNIL today. However, when it comes to the limits of the law, and let me take the data of IPMC, this allowed us to send our injuries towards different health centers. The basic problem for industrialists, but also for insurance companies, is that in the conditions that protect individual data, to be able to access normally on a daily basis to the health data that have to be accessible for us to be able to serve the interests of, from a general point of view, the interests of the patient. That's the general interest. There is a paradox, because there is the base of the IPMC that costs a certain amount a year. So, we could put that all on a little disc and so industrialists, can they use this in logics that are very fashionable? Sharing, provisional pricing. Could they base prices on the use of the product? Well, that's an interesting question. There is potential in terms of economic regulation based more on the value observed and delivered. Having said that, there will be certainly deviations, because not everything is used in optimal conditions. But I think it's important, if we go towards this, and you're referring to the possibility of setting up performance contracts that would be linked, for example, to certain indications. Certain indications might be at different prices. The data would provide an average at the end of the day, and it wouldn't be very complicated to implement all of that. I think that the basic question here, if we really want to talk about this, is the idea of breaking down another taboo, the idea that companies also have to be associated with support for patients. We can't ask a lab to be responsible for the use of its products in real life without providing services and tools that allow doctors to use that better. Today in France, let's take insulin. You can set up programs for education, but there's no support. Sending out nurses who can help patients to follow their treatment properly, filling in the titration objectives. Today, this is not possible for industry, and this leads to a second thought. We need to associate industry, and they need to help us with the proper use of their medications. So we've made progress, but we can do better. Yes, for procedures. Yes, this is what the minister was saying yesterday. So the procedure is taking too long. We know that. This is already the case with the CNIL. The CNIL works slowly. Didier? No, I'd just like to say that when you have threats, we talked about these threats this morning. Luc Ferry and Laurent drew the picture very clearly. Let's give startups, companies, industrialists, give them enough information so that they can innovate, create, and develop their activity. So what about data that we don't control? Of course, it has to be selective. So we need to think about benefits and costs when it comes to accessing data. Sometimes the benefits are better than the risk, even the risks are managed by risk management systems. Dominique, do you not agree? Yes, he does agree. So we all agree. So we'll finish this panel discussion. 35 seconds before the scheduled time. Thank you and see you next year. Thank you very much.